Okay, so welcome everyone to the Mind and Bleep surgical series. Today we're going to talk about vascular surgery emergencies, and it's a special event which is sponsored by MDU. And we are going to pick one person who's going to win a raffle prize, which is the subscription to our Sweet and Salty lecture series. So thank you very much, MDU, for sponsoring the session. So the session today, we are going to cover we're going to follow the same format as every week. So we're going to talk about the clocking, and you're going to pretend you're a trainee on call. We're going to talk about brief anatomy and pathology, disease and etiology, and some investigations that you might need. Then, most importantly, we're going to talk about initial management and some complications, and we're going to incorporate some interactive questions throughout. So the key learning points are going to be understanding the relevant anatomy of the circulatory system, identifying vascular surgery emergency presentations, understanding the risk factors of vascular surgery emergencies, and we're going to practice application of this knowledge using cases and the questions. So my name is Sara. I'm an academic FY2 doctor, and I'm interested in plastics and vascular surgery training and research. And I just wanted to briefly mention, we have a special discount code for you. We are cooperating with CPD Me platform. And if you go to mindthebleep.com/join/CPD-me, you can get a 50% discount, and it allows you to track your portfolio and build your medical teaching experience. So let's just play a short video by the MDU and we'll crack on with the session. So thank you very much, MDU. You can apply using Twitter, Facebook, or join them on Instagram. And let's crack on the session. So you're on the surgical take, you're a junior, and you have a patient coming through. So please keep this in mind as we go through the slides. So the first patient that comes through is, his name is John. He's a 75-year-old male, and he presents with sudden onset back pain and collapse, and he's sweaty and clammy. So for the session today, we're going to use Mentimeter. So I'm just going to give you a second to join. All right, so if you use the code at the top, it's 444-13900. Then you can join me on Mentimeter. And the first question is, what are differential diagnoses for somebody with back pain and collapse? So you can just have to go to www.menti, that's MENTI.com, and use the code, which is 44413900, and it's at the top of the screen. Perfect. So we have first people joining. So just a reminder for everyone, we have a 75-year-old patient who comes in with back pain and collapse, and he's sweaty and clammy. And I know this is a vascular emergency webinar, so obviously the answer is probably quite obvious, but just think about the differentials that not only involve the vascular system. Perfect. So we have some answers that cover different systems. So MI or arrhythmia, that is highly likely. That will present with chest pain, but could sometimes radiate and can present with a collapse. Kidney stones, that's a very good differential. A disc collapse, yes, if it's very painful, the patient can present with collapse and they can be unwell. Perfect. We're going to use the same code on Mentimeter for the rest of the session. But for now, let's go back to our presentation. All right. So the main differential diagnosis, you got majority of them, but the renal colic, that's a very classic differential because it does present with what we call loin to groin pain or back pain, which a ruptured aneurysm can present with as well, or just an aortic abdominal aneurysm. So this is a very important one to bear in mind. Diverticulitis, inflammatory bowel disease, or irritable bowel syndrome. A hemorrhage in the GI system that will make the patient shocked, unwell, and can cause back pain and collapse. Pancreatitis, myocardial infarction, and aortic dissection. So you got almost all of them. So well done. All right, so approach this case. We're going to follow our usual format. So we're going to take the history. In this case, might be a little bit difficult because the patient presented with a collapse. But for the purpose of this session, we're going to assume that by the time he arrived, he felt better. So we're able to speak to him. We're going to examine the patient. He's very unwell. We're going to follow the A to E approach. And we're going to think about some investigations, bedside bloods and radiology. And differential diagnosis we covered already. All right, so for the vascular emergencies, for vascular symptoms and signs, the important thing to ask about would be confusion, anuria, which essentially means that the patient is not producing urine. And that is in this case because patient's kidneys might not be perfused because of the aortic aneurysm stealing all the blood or the aneurysm rupturing. So that's a very important sign. And we have to assess for this and ask about this in a patient who might have a suspected abdominal aortic aneurysm. Leg pain, because legs are not getting perfused, or they could be an embolic event. Abnormal motor function, again, because of lack of perfusion. Chest pain, because again, of the lack of perfusion to the heart, and flank bruising, which can suggest bleeding inside of the abdomen. Systemic symptoms that we will always have to ask about: anorexia, so lack of the decreased appetite, or when the patient is not eating, weight loss, nausea, fatigue, fever, and confusion. When we're asking about the pain, I hope that you know by now that we use the Socrates. So we ask about the site, onset, character, radiation, any alleviating factors and exacerbating factors, the severity and the timeline of the pain. And for this patient, the important past medical history and past surgical history would be any peripheral aneurysms, known abdominal aortic aneurysm, renal stones, because that will be one of our differentials, gastric ulcers, again, because it can present in a similar way as a GI perforation caused by an ulcer, IBD and IBS. And we also want to know if they have any family history of abdominal aneurysms. We want to know if they smoke or if they drink, and what's their exercise tolerance. All right, so our patient, 75-year-old gentleman, the history of his presenting complaint was sudden onset back pain and collapse 2 hours ago, but he's now responsive. We're able to speak to him. He feels unwell and he's vomited 3 times. His past medical history is significant for high cholesterol. He had a heart attack 3 years ago. He has osteoarthritis and renal stones. He smokes a lot. He does have a 20-pack year smoking history. He's a moderate drinker and his exercise tolerance is poor because of his osteoarthritis. Even though he's 75, he didn't attend his abdominal aortic aneurysm screening 10 years ago because he missed his invitation. All right. So we examine him. We use the A2E approach. We check his GCS. So we have to examine if the patient is speaking to us and he's not confused, he's able to obey commands, and his eyes are responsive to just spontaneously, then his GCS will be 15. We want to know his urine output because, as I did say before, if the kidneys are not perfused, there will be no urine output, and that's important in a patient with a suspected abdominal aneurysm. And we want to examine his abdomen, check for any masses, distension, organomegaly. We want to perform a peripheral neurological exam and a peripheral vascular exam. So in this case, our patient is confused. So his GCS is not 15, is at least 14 out of 15. He's sweaty and clammy. And we examine his abdomen, and there is a pulsatile and expansile mass felt in the abdomen in the periumbilical region, so just above the umbilicus. Okay, so when we put the hands on his tummy above the umbilicus, we can feel the pulsations. Our hands normally would go up if we just feel the aorta, but our hands go upwards and outwards. So this is suggestive of a pulsatile and expansile mass. His blood pressure is 98/70, but we've already given him loads of fluids, and his heart rate is 110. So he does have some symptoms of a shock. His saturation is 91%, and respiratory rate is 26. His temperature is 36.2, and his blood sugar is normal at 5.5. His urine output is poor, and when we perform the peripheral neurological and vascular exam, there is reduced power in his lower limbs, and the pedal pulses are quite faint, and the legs are cold to touch. So it does suggest that he is not getting enough perfusion to his legs. So the way to manage this patient, as he's very unwell, the most important thing is going to be to stabilize him. So we're going to follow the A2E approach. So we're going to assess his airway and act on anything that we find along the way. So our patient had the oxygen saturation of 91%, so he's able to speak, so we're not worried about his airway. There are no added signs, but his breathing, his respiratory rate is increased, and his oxygen saturation is 91%, so we'll have to act on that. He's hemodynamically unstable, so we'll have to give him some treatment for this. And then we have to follow complete our AT assessment following the disability and exposure steps. And in this case, if you're a junior and you see a patient like this coming through, you have to escalate almost immediately as you're resuscitating the patient. So this is quite challenging because ideally you should have senior support from the very beginning. But if this is something that happens on the ward and you happen to be the only person there, then you have to escalate as you're resuscitating the patient, okay? And the patient might need emergency surgery. But it's important to get senior input as soon as possible. All right, so because John is able to speak to us, his blood pressure is still low and his heart rate is still high, but we need to do some urgent investigations to help us decide on what exactly is that he needs. Okay. So, I'm terribly sorry for that. But you can see, so his investigations, we're going to do some blood tests, including group and safe, because he might need urgent surgery. And then you can see this is John's abdomen. So we see this and we decide that it's probably best that we do a CT for him. So we've done our bedside tests. So we did the blood test, the ECG, and then we did a fast scan, so an ultrasound scan by the bedside, which showed some blood in the abdomen, and we can see that there is evidence of bruising in the abdomen. And we decided to do a CT scan because John is fairly stable. And as you can see on the CT scan here, there is, this is the aorta, and there is an aneurysm in here, which is leaking, all right? So that means that John needs urgent input. So what are we going to do for him? As I did say, we're going to do the A2E assessment, and we're going to escalate as soon as possible, all right? So we need to call our registrar as soon as we can, or we can resuscitate the patient and ask the nurses to get in touch with our registrar immediately and put out a peri-arrest call so you can get all the help that you need. So we're going to give the patient high flow oxygen via non-rebreather mask. We're going to get access. So the patient will need 2 large bore cannulae for vascular access in both arms. And we're going to catheterize the patient because we need to be able to calculate his urine output. And quite an important thing in managing abdominal aortic aneurysms in an emergency setting is that we have to allow permissive hypotension. So normally when the patients present with low blood pressure, we want to increase their blood pressure to a normal limit, so over 120, let's say. But in this case, because the abdominal aortic wall is fragile and we know that there is a perforation, so we don't want to put more strain on this friable aortic wall. So we are going to aim for the permissive hypertension of blood pressure less than 100 to not make the bleeding any worse. We sent some urgent bloods, so full blood count, electrolytes and clotting. We also did a group and safe and cross-matched over 6 units of packed red blood cells because this patient most likely will need a surgery as soon as possible. So we need to have at least 6 units, if not 10 or more, of red blood cells and other blood products to be able to resuscitate this patient properly. And those patients most likely will need to be transferred to a specialist vascular unit for the emergency aneurysm repair. So as a rule of thumb, if the patient is stable, we do a CT angiogram to determine their suitability for the endovascular treatment. If the patients are unstable, then we have to immediately transfer them to theatre for open repair. But again, that depends on where you're at. If there is a vascular department in your hospital, and also if the patient does not have any past medical history of abdominal aortic aneurysm, sometimes this is a very difficult decision to make because we might be going in blindly if we don't do a CT. So obviously this is a decision that your senior will have to make. Okay, so a ruptured aortic aneurysm, which you can see in here on the right-hand side of the screen. So if you can see in here, there is a lack of continuity in the aortic wall, and there is blood leaking into the abdomen. Okay, the ruptures of the abdominal aortic aneurysm cause about 3,000 deaths a year in the UK, and the risk increases exponentially as the diameter of the aneurysm increases. Most of them, and this is the case in here on the slide, rupture posteriorly into the retroperitoneal space, and then most often hematoma forms and the bleeding is contained. So that will make the patient stable enough to get to the hospital and get to the operating room, even though the patient might be unwell, and that has a better prognosis. If there is an anterior rupture, there's no hematoma formation, there's free blood in the abdomen, and it just continues to bleed. Those patients, most of the time, don't even make it to the hospital, and they unfortunately pass away. The risk factors for having an aortic aneurysm and for the rupture, actually in particular, the risk factors that increase the risk of rupture is smoking, hypertension, and being a female. And the classic triad of ruptured aortic aneurysm is going to be flank or back pain, so one of the two, with hypotension and a pulsatile abdominal mass. So in John, the patient that we are looking after at the moment, he had this classical triad. So he had back pain, he did have hypotension, and we did feel the pulsatile abdominal mass. So he presented with this classical triad. And other symptoms can be any signs of shock, syncope, so collapse, and abdominal pain or loin pain. An abdominal aneurysm, aortic abdominal aneurysm, is in general defined as a abnormal dilatation of the abdominal aorta greater than 3 centimeters. It is seen in 1 in 70 men who are aged over 65, and the causes for having aortic abdominal aneurysm are mostly atherosclerosis, trauma, infection, or connective tissue disease. So I think in our practice in the UK, atherosclerosis, so calcification and this fatty plaque deposition, which is linked with, which is caused by the cardiovascular risk factors that a lot of our patients have, such as smoking, hypertension, hyperlipidemia. So those patients are at risk of developing a AAA, as we call it. So other risk factors are increasing age, family history, and male gender. So people who are males are more likely to have an abdominal aortic aneurysm. But if you have an abdominal aortic aneurysm and you're female, then you're at higher risk of a rupture. Interestingly, diabetes is a negative risk factor. So it's a protective factor. So people with diabetes tend to have less AAAs than the general population, and we still don't quite know why that is the case. And the symptoms of AAA, it can be asymptomatic. So it can be an incidental finding on a screening or just on a CT or another scan done for a different indication. It can present with abdominal pain, back or loin pain, or leg ischemia, because in the sac, as you can see in here, very often little thrombi form. So you have little clots forming, and even though the blood is still flowing, those there's a very chaotic flow inside of the aneurysmal sac, and the clots from here can then be flicked to the arteries that supply the legs, and the patient can present with limb ischemia. So essentially lack of perfusion with blood to the legs. Okay, so I just wanted to quickly tell you a little bit about the anatomy of the aortic aneurysms. So if you look at the picture on the left, this is how the healthy aorta is supposed to look like. So you have your, if you just look in here, so this is the human body. And then when we look in here, this is the aorta. Okay. And these are the renal branches, and these are the common iliac arteries. And on the other side, you can see the abdominal aorta with an aneurysm. So again, we have our aorta and then the aneurysm, and then that is very close to the renal vessels in here. Most of the aneurysms in the aorta are fusiform. You can see it in here. So it's kind of expansion, equal expansion in all directions. And sometimes we see saccular aneurysms, as you can see in here. So it's like an outpouching. And that is seen more often in cases of trauma or infection. So the aneurysm that we are talking about mostly is going to be a fusiform aneurysm. And then there can be different locations where the aneurysm develops. So you have a suprarenal, so it's above the renal arteries, pararenal, so it's just near the, and same with juxtarenal. So the pararenal will involve the renal arteries, juxtarenal is nearby, but it doesn't affect the renal arteries as much, and the infrarenal aneurysm. So these are your 4 main types in terms of location. And in the UK, because we know that abdominal aortic aneurysm is found in 1 in 70 men over the age of 65, we do have a national abdominal aortic aneurysm screening program. And the way the program works is that all men on their 65th birthday get invited to have a one-off abdominal scan of their abdominal aorta. Okay, so they get the ultrasound scan, and it's a one-off, unless we find an aneurysm. So the program has shown that there is a 50% reduction in aneurysm-related mortality for people who do take part in the screening. 1.1% of people who attend the screening are diagnosed with AAA, and the treatment is offered to patients who have the abdominal aortic aneurysm that measures over 55 millimeters, and that is 0.32% of those screened. And in general, we consider surgery if it's over 5.5 centimeters or if it's expanding more than 1 centimeter a year. So it's kind of it's kind of simple. So that if the aneurysm is over 55 millimeters or 5.5 centimeters, or is at this threshold, then we offer treatment. If it's expanding rapidly, we offer treatment. But what do we do for patients who do have aneurysms, but they're smaller? So any abdominal aortic aneurysms that measure less than 55 millimeters are monitored with a special ultrasound, a duplex ultrasound. So if their aneurysm at the first screening meeting is between 3.0 to 4.4 centimeters, they get ultrasound once a year from then on. If their aneurysm is 4.5 to 5.4 centimeters, they get ultrasound every 3 months. So this is something that you can always look up. This is not something that you necessarily have to remember, but it's just, I thought it's just interesting to know what happens to those patients. Those patients who do have aortic aneurysm in their abdomen, they have a 3% risk of cardiovascular mortality. So the most important thing that we can do for them, if they're not yet at the threshold for the operation, the very important thing to do is to reduce their risk factors. So we need to offer them smoking cessation advice. We need to control their blood pressure long term, and we need to make sure that they're on the best medical therapy. So for those patients, it will most likely include a statin and aspirin, and we should advise them to lose weight if they are overweight. And the surgical management for abdominal aortas, there are two main approaches: an open surgery and an endovascular surgery. So on the left-hand side of the screen, you can see the open repair. So essentially, we open the whole abdomen. It's a big surgery that takes quite a long time for the patients to heal afterwards. They have a clamp above the aneurysmal sac and at the bottom, and here on common iliac arteries. And then we open the aneurysmal sac. We put a graft, like a tube graft, inside, and then we suture the aneurysmal sac, which is slightly excised and reduced around the tube graft. And then we have to close the abdomen and do everything else. So in emergency setting, if the patient has a known AAA and we don't have an up-to-date CT scan to see if they're suitable for endovascular repair, they will go to have an open repair. The endovascular repair has a lower, it's less invasive, essentially. So as you can see here at the bottom of the screen, this is the patient's groin. The way we put in the stents in the endovascular repair is by using the common femoral artery. So we make a small incision in the groin, and then we put all the catheters and the graft through this little cut in the groin, and we can do cuts on both sides. So then we can put all the parts of the aneurysmal of the graft inside it. but I think essentially not all the patients will be suitable for endovascular repair. So this is a decision that has to be made based on the case, like individual case basis. And the post-operative management for those patients, as I did tell you before, if the aneurysmal sac is expanding or if the abdominal aneurysm is leaking, then there's a risk that essentially all of the major organs, including your brain, your kidneys, might not be perfused well. So after a surgery like an open or endovascular repair of the AAA, we have to do regular neurovascular observations in all 4 limbs to see if there is good perfusion. We need to monitor urine output to check if the kidneys are okay. We need to monitor a patient's consciousness state, or a GCS, to monitor the brain perfusion. We're aiming for a normal blood pressure. And we, as after every surgery, have to monitor for any bleeding for surgical sites and any opening of the wounds. And for those patients, we do a CT on day 2 to check if the graft is in the right position. Okay, so I told you a lot of information. So we're going to do a quick recap on Mentimeter. So you have your code. If you just go to Menti, we're going to go for some questions. I'll wait for everyone to join. And the first question is, at a routine screening ultrasound scan, an asymptomatic male has a 4.1 centimeter abdominal aortic aneurysm. How often do you think he needs the surveillance scan? I'll let more people join because we're going to do a couple of questions in a row, so we're not going back and forth. So 4.1 centimeter abdominal aortic aneurysm at a first routine screening. How often does the patient need to come back for his ultrasound? All right, so a great majority thinks it's every year. And I hope this is going to work for me. And that is a correct answer. So it's every year. And we essentially, if it's 4.5 to 5.4 centimeters, we'll do it every 3 months. But if it's less, so 3 and higher, and that includes 4.1, it'll be every year. Well done, guys. The next case is a 75-year-old male who presents with known aortic abdominal aneurysm, and he presents with a collapse. He is hemodynamically unstable. So what's the best definitive management for him? So the options are open repair, endovascular repair, a CT scan, or fluid resuscitation. All right, so well done again. Majority of you got the answer correct. It's an open repair. So in this question, the buzzwords are that he has a known AAA, he presents with a collapse and a hemodynamic instability. So he's definitely not fit enough for the CT scan. And we can't do an endovascular repair without a CT scan to help us plan everything. And another buzzword in here is what's the best definitive management. So definitive management is essentially what do we have to do to ultimately help this patient. So this is why the answer is open repair, not fluid resuscitation, because yes, we'll have to do the fluid resuscitation at the beginning, but a definitive management is going to be the open repair for the patient who has a known AAA and comes in with a collapse and hemodynamic instability. Well done. All right. So now we have a 75-year-old male with a known AAA, the same patient. He presents with a collapse and he's hemodynamically unstable. But this time, what's the best initial management for this patient? So we have 4 different options. All of them suggest that we should use the A2 approach. And then do we aim for permissive hypotension, normal tension, we don't fluid resuscitate, or we resuscitate, but there's no blood pressure target? Awesome. So once again, you guys got it mostly right, so well done. In a patient who has a known AAA and presents with a hemodynamic instability and a collapse, we're going to do A2 assessment and we're going to aim for permissive hypotension. So as I did say, we're going to try and save this fragile aortic wall. And this is why we're going to aim for the blood pressure of less than 100. But obviously you'll need senior support for that. And it's only after the surgery that we aim for normal tension. So 120 and thereabouts of a systolic blood pressure. Well done. All right. Now, what is the classic triad seen in aortic abdominal aneurysm rupture? The last option is chest pain. Sorry, I cannot spell. Perfect. Let's wait for a few more people. All right. So again, you guys got it right. So I'm glad that that you are listening. The classic triad is going to be abdominal or back pain or flank pain with a pulsatile mass and hypotension, so low blood pressure in those patients. Okay, perfect. All right. So a 65-year-old man attends a AAA screening ultrasound, and he does have an aneurysm that measures 3.7 centimeters. What is the most important management to reduce his cardiovascular risk? They're all very important, but if we can think of what might be the most important, if you were to pick 2. Fabulous. You guys can't be fooled. This is correct. So because we know that high cholesterol and high blood pressure increase the risk of having an aneurysm and the aneurysm rupturing, then we will have to make sure that the patient's cholesterol and blood pressure are controlled. But obviously, if the patient's diabetic, long term is really important to ensure their blood glucose control is adequate as well. Okay, so I'm really sorry for flicking back and forth, but you guys have to bear with me. All right, so just to finish off our first case, I told you there are two different types of repair of the abdominal aortic aneurysm: an open repair, when we put a tube graft, or an endovascular repair, when we put this this porous material kind of a graft in, which you can see in here. So this is a graft with fenestrations to make sure you don't close off all the branches coming off the aorta. And it has few parts. So as you can see in here on the graft, you have the main body, which has one side of it is like long trousers, like jeans, and the other one is short, like you kind of made shorts of the one side of your trousers. And the way we put it in is we put the main body with the long trouser part in, and then we put the rest of the graft separately. So there are some problems that the patients may encounter, and we call those endovascular leaks. And that happens when there is an incomplete seal, and essentially the blood can still go into the aneurysmal sac, and the disaster can still happen. So there are 5 different types. I thought I would just quickly mention them, but I don't think there's any need for you to know them in detail. But you just have to know that some of them are leaks under high pressure, and those will need operation straight away. Okay. All right, so second case. This one's going to be shorter, I promise. The case is Anna, a 65-year-old male. He presents with a sudden, cold, and painful right leg. She's unable to weight bear, and she has this tingling sensation in her leg. So what do we think could have happened? So the differentials in here could be chronic limb ischemia, acute limb ischemia, acute DVT, so acute clot in one of the veins of the legs, a spinal cord or peripheral nerve compression because she has this tingling and a pain, or compartment syndrome. So in this case, again, we use the same approach. We're going to take the history. We're going to examine her using A to E approach. We're going to do the investigation starting from bedside for bloods and radiology. And we're going to, as we have already done, think of some differential diagnosis. So in this case, Anna tells us that 3 hours ago, her leg became suddenly cold and painful. And the pain is mostly felt in her forefoot, so at the most distal part of your foot. And she's unable to weight bear, and her entire leg is tingling. Her past medical history includes intermittent claudication at 50 meters. So intermittent claudication is this, this is seen in, it's essentially pain either in your calves or in your buttocks. And it's seen in patients who have peripheral vascular disease, in particular peripheral arterial disease, because when they're walking, the blood supply cannot match the demand. And then the muscles essentially are starved of oxygen, starved of blood, and the patients start getting pain, and that stops them from walking. So she gets intermittent claudication, so this pain in her calf, at 50 meters, so she has to stop. And this is something that she's had for a long time. She had a heart attack 3 years ago, not 5 years ago. As I did say on the slide, she had a mini stroke 2 years ago, and she's a type 2 diabetic. So we're going to examine her. We're going to use the A2U approach again. We're going to do a peripheral vascular exam, paying special attention to pulses, temperature of the leg, color, capillary refill time, and any swelling. And we're going to do a peripheral neurological exam, looking to see if her sensory and motor function are normal. All right, so we examine her. Those are her feet. And as you can see, the right one looks pretty dodgy. So she's alert and awake. the right leg is pale and it's very cold to touch. We're unable to see what the capillary refill time is on the right, because essentially when we press, because what you want to see in the capillary refill time is you press, it goes white, and then it kind of goes back to your normal skin color, and you count how long it takes to get there. So we're unable to do that because the foot is so white. And then she doesn't have any sensation in the most distal part of her foot. And she, even though she's not moving, she's now complaining of a pain in her leg. The motor function is mildly reduced. So she's able to move her toes, but just about. And she can move her ankle, but the range of motion is slightly reduced. We do the arterial duplex. So we use this, what we call handheld Doppler machine. By the bedside, we put some jelly on the artery, and we put it on, and we listen for any signal. So in her case, there is no signal audible in any of the arteries of her leg. So what are some other investigations we're going to do? Well, we have to do the bloods. So as always, we're going to do full blood count. We're going to use an ease to check for electrolytes and their renal function. We're going to look at the liver function, CRP. We're going to check for some clotting. So does the patient have any clotting disorders? That will mean that she's more likely to have some clots that will stop the blood flow to the leg. We're going to check for lactate to assess for tissue ischemia. So essentially, when the tissues don't get enough effusion, the lactate will go up. We'll do a group and save and a cross-match in case the patient needs an urgent surgery. And we're going to do a thrombophilia screen to see for any clotting disorders that could have caused that. We're going to do an ECG. And in this case, the patient is in sinus rhythm, but she's tachycardic. We're going to check her urine, but there's nothing on her urine depth. We're going to do a duplex ultrasound, and eventually we're going to do a CT angiography. So in the case of this patient, you can see a nice 3D CT reconstruction of her arteries. And on the left side, you can see aorta in the center, and then we can see the common iliac, and then we can see the common femoral, and then we have the common femoral artery here, and then it nicely becomes the profunda femoris and the superficial femoral artery here. But then when you look on the left, there's nothing here. There's something that's obstructing the flow on the right side, and then in here we can nicely see what level it stops opacifying. So that will help us with the surgical planning. So the patient, as probably the title of the talk has already given away, presents with one of the vascular emergencies, which is acute limb ischemia. So it's a surgical emergency because it threatens the leg viability. Essentially, you probably have heard people say that time is leg in that situation. And the surgery in patients with severe acute limb ischemia need a surgery within 6 hours to save their limb, and in some cases to save their life as well. So it's caused by sudden decrease in limb perfusion, and the classic presentation is a mnemonic of 6 Ps, which you can see here on the little diagram. So the patient presents with pain and paralysis. They don't have any pulses. There's paresthesia, so they can't feel you touching them. There's loss of sensory function. The leg is pale and it's perishingly cold. And the reasons why some people might get acute limb ischemia is because they have an embolus. So essentially there is a clot somewhere and then it travels elsewhere. So that's an embolus. So people who have prosthetic heart valves or abnormal heart rhythms, such as atrial fibrillation, people who had a heart attack and have some thrombus inside their heart, or people who have aortic aneurysm with those little thrombi that I told you about inside the aneurysmal sac, can have the embolus that travels somewhere and causes this decreased leg perfusion. Or sometimes people can have a thrombus developing in situ, so essentially in the same side where it causes occlusion. And that is seen in patients who have peripheral arterial disease with this calcification and atheroma plaques throughout their vessels. So in the heart, if people have a plaque, it will present with angina, or the patients might have a myocardial infarction. And in the leg, the same process will present with acute limb ischemia if the plaque builds up enough and then ruptures to occlude the blood flow. So essentially, in this patient, she's had a chronic peripheral arterial disease, and this is evident by her intermittent claudication, this pain when she walks. But now she has developed acute on chronic limb ischemia, because now all of a sudden she has pain at rest, her leg is pale, and she will essentially need us to do something to save her leg. So what are we going to do for her? We're going to use an A2E approach, and we're going to escalate her senior straight away. We're going to give her high flow oxygen, IV fluids, we're going to catheterize her, and we're going to aim for strict fluid balance. An important thing in here is, because there is an obstruction, we have to make sure that the blood is thinned so it doesn't get worse. So we're going to put her on IV heparin infusion as soon as possible. And the reason why we're putting her on heparin infusion, not on, for example, low molecular weight heparin, is that IV heparin infusion is easily reversible if need be. So if this patient needs to go to surgery, we don't want to risk her getting a high dose of low molecular weight heparin and then us having to wait to be able to operate so she doesn't bleed from elsewhere. So we're giving IV heparin, easily reversible if needed. And the patients will need surgery within 6 hours. Unfortunately, sometimes the limb is non-viable and it's a threat to life. So those patients might need amputation in the worst case scenario. And we have to monitor for reperfusion injury. So in those patients, when the blood flow is occluded for a long time, and then the blood starts flowing again when we repair it, they're at risk of kidney injury and a compartment syndrome, because when there's no blood flow, a lot of swelling develops, and then the muscles might start dying off and everything is swollen, and there is a risk of a compartment syndrome. So the surgical management, in this case, there are some options. If it's an embolic cause, so there's a clot somewhere and it travels elsewhere, we can do an emergency embolectomy, so removal of this embolus with a Fogarty catheter. So you can see it at the bottom, and here at the top you can see the tips. So it's essentially a long catheter that we put in the vessel, and it's deflated, so it's same diameter throughout when we put in, and then we inflate it so it increases in the diameter, as you can see in here. There are different sizes, and then you pull it out, and as you do, essentially if it's an embolus, you'll see something like that, then an embolus coming out. And then your other options is local intra-arterial lysis or bypass surgery. So the bypass surgery will essentially, if let's say there is an occlusion here on the picture, you'd want to use a vein graft or a prosthetic graft to join a patent vessel with a patent vessel, essentially bypassing the obstruction. So again, same as in the heart, when we do a coronary arterial bypass grafting, we're just connecting two patent bits of the arteries to bypass the obstruction. If it's a thrombotic cause rather, we can do an angioplasty. So we can, as you can see in here, we can put this special balloon inside of the vessel and kind of squash the plaque that caused the occlusion, and that will increase the diameter of the vessel. Or again, we can do the local arterial lysis or a bypass surgery. the post-op management for those patients, regular neurovascular observations of the affected limb. We have to make sure that whatever we have done is working and the blood is flowing to the leg. We're going to keep them on a heparin infusion because we want to keep their blood thin so they don't occlude again. And then we have to look out for those complications by assessing the patient regularly and doing regular blood tests. So those patients are at risk of myoglobinuria. So essentially, as the myoglobin is released from the muscles are damaged because of the lack of perfusion. When that gets filtered by the kidneys can be damaged. We have to look out for compartment syndrome. So classically, pain on passive stretching and tense muscle compartments, any acidosis or hyperkalemia. Again, that's linked with tissue ischemia and lack of perfusion. And the long-term management for those patients may be reduction of cardiovascular risk factors. So same as with AAA, weight loss, smoking cessation, regular exercise. They should be on an antiplatelet therapy long-term, so either aspirin or clopidogrel. And in the long term, we have to investigate the possible causes. As I said previously, we might think about thrombophilia screen or vasculitis screen, but this is something that's not going to be done on the acute day of the admission. This is just something that we need to think of in the future. All right, and before we move on to the summary, I have just a few last questions for you, and we'll be done. So, which of the following, guys, is not a risk factor for acute limb ischemia? And we'll have one more question after that, and we'll wrap up. All right, so very well done. COPD is not a risk factor for acute limb ischemia. Having a metallic heart valve or abnormal heart rhythm, such as atrial fibrillation or smoking, is a risk factor for acute limb ischemia. And the last question. So the patient was treated for acute limb ischemia, then becomes hemodynamically unstable, and their ECG shows ventricular tachycardia. What electrolytes should be checked? This is a bit of a tricky question. Or it might be. So which electrolyte will be deranged in patients with acute limb ischemia and potentially compartment syndrome that could cause ECG changes such as ventricular tachycardia? Fantastic, guys. It is potassium. Those patients, when they're ischemic and the masses are damaged, they will release high amounts of potassium, and that puts them at risk of ventricular tachycardia. Well done. We're going to be done in 3 slides, hopefully important ones. So just to recap, most abdominal aortic aneurysms are asymptomatic and are found incidentally. And we do have a screening program for everyone at the age of 65. Surveillance is with ultrasound scan, and the CT scan is required when we think about the surgical planning. If somebody has a small abdominal aortic aneurysm, their risk factor reduction is crucial for them until they get to the threshold of where they need surgery. If the patient is symptomatic or unstable, we have to escalate immediately and do the ATE assessment. And then acute limb ischemia most often presents with sudden onset of pain and pallor of the leg. CT angiography is the gold standard investigations for acute limb ischemia. So this little scan that you saw where there's a level of the occlusion visible. The surgical management will depend on etiology, and I told you some different options. Post-operatively, we have to monitor for reperfusion syndrome, hyperkalemia, acidosis, and we have to identify causes for acute limb ischemia and optimize what we can do. So essentially the modifiable risk factors. And just to remind you, you can access our free surgical webinars on mindableep.com/surgery. We have added some new articles recently, so please go and check them out. And most importantly, please do fill in the feedback form, because we want to know what you think and constantly make our sessions better. So you get exactly what you need. And there's the link as well. I hope it does work, but I might put it in the Facebook link as well in a second. And the next session next Monday is going to be on ear, nose, and throat, common presentations and some emergencies. And this is going to be a penultimate session of the Surgical Mind the Bleep series. So we're going to be saying goodbye soon, but I hope you enjoyed it. Please scan the QR code. I'll post the feedback link in the chat in a second as well. And in the meantime, do you guys have any questions? And if you do, I can check them out on Facebook, not on my email. All right, are there any questions? Let me copy the feedback link. But also for everyone who's interested, Mind the Bleep is expanding. So we're not going to go for long, but we're going to create specialty specific webinars. So the surgical sessions are now going to become loads of different subspecialties, because it looks like you guys enjoyed it. So we're going to launch a lot of subspecialties. Yes, question about the infusion of heparin. Let me have a look. Oh dear. Oh yeah, we're not waiting for the thrombophilia screen to take somebody to the operating room. That was not a suggestion ever. It's just if we're taking bloods, might as well take them for the thrombophilia screen. But this is something to do later on. Yeah, potassium would be the main offender. Okay, so the potassium is going to be the main electrolyte deranged here because of the compartment syndrome and ischemia. And then not to confuse things, but yes, calcium gluconate is the first step treatment for hypercalcemia, but this is for another time. And do you guys still have a question about the heparin infusion? I can't see it. Oh, dose of heparin given initially after the surgery. So the dose of heparin in every trust, it might be different, but essentially in the trust with our work, for example, we use a blood test called anti-10A factor level, because the heparin will target factor 10A. So essentially, we want to see if it's working well enough by assessing the levels of factor 10A in the blood. And the way we do it is there is a hospital protocol, and we're aiming at the factor 10A level of 0.3 to 0.7. There is this, you just have to look at the prescription in the hospital, but essentially, we give, there's a specific amount of units per kilogram that we give to patients, and then we take a blood test 4 hours after. And then depending on the level of factor anti-10A, we'll either give more heparin or less heparin, or switch it off or give a bolus. But there is a very specific hospital protocol, which I'm not sure if you can guys access online, but it will be in every hospital trust. If you look for unfractionated heparin infusion dosing. And whenever I do it, I have to, whenever the blood tests come back, I have to go and read through the guidance again to see what I need to do, because